Today we'll be talking about disc herniations. It's a review, but so much is important set by this topic that I think it's in order to re-look at this again. It's much shorter than previously, and again, if it's not a review and it's more of a relearn, then go back to the other videos and also discuss this with your instructors on the Zoom sessions and in class. It's an important topic. Before we get into disc herniations, let's look at some of the more common, or at least in one case more important, disc lesions that are non-herniated. So the first one is not very common. It's about 1 in 100,000, perhaps as high as 1 in 200,000 people get this in the industrialized nations. Apparently in Africa, in the less industrialized areas, the incidence could be as high as 1 in 10. But where you are, it's not very common, but it's an important consideration. This is discitis. It's often, if not usually, associated with osteomyelitis, and it's caused by a bacterial or viral infection, which may be introduced at surgery. Pelvic disease apparently may well spark off this, and the lumbar spine is the most common area for this, followed by the cervical spine, and lastly by the thoracic spine. There are two peaks in this group. Well, it peaks around about 7 years of age in children, so these kids get it. It's very rapid onset and it's quite acute. These children don't want to walk and they'll arch their back to take the pressure off of the disc, presumably. The way to recognise this is you've got a 7-year-old with back pain, basically, and you should be getting this. So any child who's not an athlete should not be complaining of adult problems. Back pain, for example. So whether it's osteomyelitis or something else, be careful of children with adult problems. The other age is over 50, and where it tends to be slow and gradual, it can become chronic. In both cases, there may be temperature increases, body temperature increases, or there may not be. Both of them, though, if they're not recognised and treated with antibiotics, if it's bacterial, can be extremely damaging, and it will eventually destroy the disc. And it won't do a lot for the vertebral bodies neither. Traumatic annulus tear, the outer layer tears. Now we get degenerate tears, obviously. The annulus does tear degeneratively. These are horizontal clefts, which is arguable whether it is actually a tear or whether it's just a separation of the lamina. But on the outside layer, this is where more traumatic tears are occurring. So this is going to be caused by very, very high injury trauma forces on the disc in a healthy disc. But probably this is less severe, the trauma, but it's imposed upon a degenerate disc which is already predisposed to tearing. But even so, this is not terribly common, although whether or not we recognise it is another matter. These people will have central back pain following trauma, or at least a trigger, and it's going to be caused by either by flexion and rotation or extension and rotation forces, and clinically it's going to be difficult to tell what's happening. Rotation is obviously going to be painful, flexion or extension does, so this could look like biomechanical dysfunction. It will not respond to manipulative treatment. Doesn't necessarily hurt them, but it's not going to respond, so fire this back. Metaplastic proliferation is a relatively recent discovery. It started when they started biopsying the material that was external to the disc, which were considered extrusions, and it was found that this was new collagen. So this is new growth on the outside of the disc. Quite possibly is caused by an annular tear, traumatic annular tear, or a semi-traumatic annular tear. And basically you get overhealing. So you just get the equivalent of a keloid on the outside of the thing. And it depends on how big it is and what it presses on as to whether it's going to be symptomatic or not, and how bad those symptoms are going to be. But if it's bad enough and it's pressing on the dura or on the nerve itself, and it damages the nerve, you're likely to see a radiculopathy with looking very much like a disc herniation. You're not going to get very far with treating this unless the inflammation is mediating it. A disc protrusion is a bulging of the disc. It can be focal or non-focal, but there's no migration of nuclear material. So possibly what it is a radial tear, and it's causing a weakness in the disc in that direction. It bulges out that way. They can be fairly large or not very large. They can cause pressure on the dura, so you have a positive straight leg raise. An extension is going to be your problem, probably, because it's going to act to block the joint, so it's likely to restrict that. But going into flexion, again, you're going to be pulling the nerve root or the spinal nerve onto the bulging disc, and that may give you dural pain going down the leg. It's not going to be as severe by any means as the proper herniation. It's probably what happens with the metaplastic proliferation, except there's no invasion of blood vessels nor keloid, and this radial tearing and exposure of the blood flow to the nucleus allows the nucleus to herniate through the annulus and become a prolapse or an extrusion. So now we get to the meat of it. These are the herniations. We basically have two: the contained herniation, the uncontained herniation, which is what we all know and love. The migration of the nucleus through the annulus, either complete, which is an extrusion, or incomplete, which is a prolapse and it's a bulging of the annulus, or it's fragmentation of the extruded nucleus in the form of a sequestration. So these are catastrophes, all right? Either the uncontained herniation is asymptomatic completely, or within a very short period of time, 2 to 3 weeks usually, this goes from backache to really severe disabling pain in the back and down the leg. Apart from that early progression in the beginning, you don't see mild disc herniations. These are a major problem for the patient. They're almost basically, you can't mistake these for what they are. This isn't a diagnostic problem at all. So, and then the second one is the internal disc herniation, the internal derangement of the disc, or the contained herniation. I'm beginning to like internal disc herniation better than the other two. So this is a non-focal migration of the nucleus within the annulus, and basically it spreads through the annulus, and when it reaches the outer part of the annulus, which is nociceptive, then you may get pain with this. So we're going to look at these two in a bit more detail now. So the internal disc herniation. The left figure is a normal segment. The nucleus is actually, the outer nucleus is indistinguishable from the inner annulus. They blend together and they're well joined. This isn't a puddle of water flopping backwards and forwards in the disc. That doesn't happen. This is constrained by the annulus. What's believed to happen is that the nucleus actually herniates upwards into the end plate or possibly into the vertebral body. There it's exposed to the blood flow, and vascularization of the nucleus changes it. It chemically changes this. So it becomes more, or rather less viscous, and it unbinds from the annulus and it's more mobile now. It's also toxic to some extent to the annulus, certainly to the nerves if it does get outside. So this is the beginning of the contained herniation and may well be the beginnings of some of the uncontained herniations as well. So on the left we have the degenerate disc. So we have horizontal clefting, separation of the lamellae of the annulus. No radial tear in this one. That is the next step into degradation, but this is degeneration. So we have this randomized horizontal clefting. We also have the nucleus exposed to the blood flow. So the nucleus changes and then it starts to work its way through the annulus. Initially through the horizontal clefts, it will work its way through, but then it will also erode the annulus and it'll start working faster and more randomly, if it can get any more random. So this is how you see this thing, and then once it hits the nociceptive part of the annulus, it may or may not become painful. The ones I've seen have had a trigger. They've sat for too long, they've slipped, something's happened to them, fairly minor, and then this thing builds up and builds up. Whether that happens in all cases, I don't know, but the ones that I've seen, it's been triggered. So this is what it looks like, and I'll show this on a CT scan. Now, just before I get to the CT scan, they do a discogram. Definitively, the discogram shows what this is. So they'll inject a dye into the disc, and the disc shows up the herniation clearer than if you just do a plain CT, but a plain CT will show it as well. But the other thing it does is it increases the intradiscal pressure, which then causes pain if this is a painful tissue. So you may have 2 or 3 levels where you have this contained herniation, only one of them giving pain, and so you know which one it is by which one you've injected. You can also do the reverse. If it's painful most of the time, then you could put an anaesthetic into it. I think it's lidocaine, but I'm not sure. But you can inject an anaesthetic into it, and that will help it. So this is the way diagnoses are made, either by causing pain via the discogram or relieving pain by local anaesthetic. Okay, so here's the herniation. On the left A, you can see basically the vertical herniation into the superior vertebra, can go inferior as well, and then the spreading of the nucleus out. And this is looking down to, and you can see the way it's spreading through there. Like so. Now they have done experiments with healthy, well, degenerate but otherwise healthy discs, and they put a cut through this, through the annulus, so that scalpel right through it. So there's no doubt about it, you've got an opening right away from the outside into the nucleus. And then they've tried to make the nucleus herniate through the annulus by biting it, throwing it against the wall, driving a car over it, squeezing a vice, doing things to try and make it squeeze through, and they couldn't do it. So it looks like this has to be changed, probably by blood. And then those changes that allow it to herniate, whether it's this type of herniation or the other type of prolapse, and I'll come to that in a second, how the blood can get to that. And this is another image. What's clear with this one, the one on the right there, is it's worse than the other one. What's clear here is that this is random, so it's almost certainly going to cause bilateral pain. The pain could be in the back, could be down the legs. And this is purely discogenic pain. The disc isn't bulging, it's just the disc is painful and referring pain away from itself. And it's easily mistaken for a disc herniation, at least superficially, and you need to be careful that you don't take it as an uncontained herniation. So if we look at the diagnostic criteria here, it's progressive. The pain gets worse and worse and worse. In fact, it can be so bad that its treatment is to remove the disc entirely, cage the segment, and then the patient's okay. But it can be that bad. So it's very rarely unilateral, it's almost always bilateral. It's asymmetrical, so one side is worse than the other. You'll find the pain going further down the leg on one side than the other. It can go all the way into the foot, it can do all sorts of things when it gets bad enough. There's pain on sitting, standing, extension and flexion movements. There's a degree of obligate impairment here as well. The patient does have problems working, but the obligate impairment isn't as obvious as it is with a uncontained herniation. They can walk for a while and then the pain starts to get them down a bit. Sitting, the same sort of thing. So the obligate impairment isn't as obvious, but there are things they can't do that will really stress this out. They're more comfortable in laying. There's no neurological symptoms. The straight leg raises are either negative or only mildly positive. So when you get up to 70, 80, 90 degrees, it starts to flex the lumbar spine, and that compression then causes the pain. But it's not a neuromeningeal positive. PAs over the affected segment are positive plus, depending on what stage you're seeing them at. Obviously, if it's in the very early stages, it's going to be much less severe than later on. And the age is usually under 30 years. Just on the side, the treatment for this is either surgery when it's bad enough, but you can inject hypersaline into the disc, which will presumably destroy the nociceptors. There's also an electrical treatment, endothermy, discal endothermy. So you put a wire into the outside of the into the disc, but running around the outer layers of the annulus, and then you heat it up a few degrees above body temperature. And a couple of applications of this, when it works, really works quite well. Again, whether it's changing the makeup of the disc or destroying the nociceptors, I really don't know. Now the uncontained herniation. Okay, so what we have on the left now is not degeneration of the disc, we have degradation. Because now these radial clefts have aligned themselves and we now have a radial tear through this. The disc will get thinner in this case, while with degeneration, of course, it gets higher. So this is degradation. Now that will allow a pathway for the nucleus to flow through, if you like, but it has to be changed. So it's either going to herniate vertically, or there may be a tear here, with basically invasion of blood vessels trying to heal the tear and eventually reaching the nucleus, and then the nucleus can herniate way back that way. So this is the beginning of it. Then you get bulging occurring, and the prolapse, you have the annulus bulging out like so. With an extrusion, it will come external to the disc this way, and that can cause some real problems. Simple contact with the nerve can actually cause it to degenerate. It's neurotoxic, so it can degenerate the nerve. Sometimes it will go into the transforaminal canal, or rather into the transverse canal, become transforaminal, and then there's a lot of pressure in that canal because it's an enclosed space. So now the disc is subjected to a lot of pressure and the nucleus. So not a good scenario here. And once it's extruded, the prognosis isn't that great for physical therapy. So here we have a discogram of a prolapse. What you can see is we also have a internal herniation at the nucleus around here, but the external, the uncontained herniation is sitting right there. And this is actually median, mostly though it will go posterolateral. So this is the uncontained herniation. On this view, you can see it sitting there. And basically this is your prolapse, or maybe an extrusion. It's difficult to tell from an MRI. Or it's difficult for me to tell from an MRI. That's a better way of putting it. So, diagnostic criteria. The disc itself: severe unilateral low back and leg pain, severe deformity, so kyphorhodoscoliosis. This is not like the Mackenzie shift that just goes sideways. This thing is flexed and basically rotated and slight flex. So it's a kyphorhodoscoliosis. Range of motion loss is serious in all directions. It's both a flexion and extension impairment. Certainly the extension is an obligate impairment. They can't walk with this, they have to limp. And it's not that this hurts worse when you sit down and when you stand up it feels better. That doesn't happen. It's a myth, and it's not true for disc herniations. PAs over the affected segment are severely positive, with spasm usually, and straight leg raise is very positive. It's rare to see this to be positive only over 60 degrees. It's usually a lot lower than that. Possibly minus n degrees if the crimp has been taken out by the disc. If there's a radiculopathy, it's any one of the following: segmental weakness, segmental hypoesthesia, segmental hyporeflexia, or neuropathic pain. Any one of those basically defines this as a radiculopathy. It's a catastrophe. And then the discogenic cauda equina. Picture shows it quite nicely here and also here. And this picture, well, they both do actually. You can see how the spinal canal, or the contents of the spinal canal, are seriously narrowed here. They're compressed backwards. And this thing goes either median or paramedian. It compresses multiple nerve roots, and it causes really severe problems, and it can lead to permanent bladder and bowel dysfunctions and genital dysfunctions as well. So this is not something that you really want to play with very much. Okay, so the diagnostic criteria for cauda equina syndrome, and I can't believe anybody's going to have a problem with actually diagnosing this. Severe bilateral low back pain. It's worth noting though that if this is not from a disc and it's from a tumour, a neurological tumour, then you're not going to see this severity of pain. Most of it is going to be neurological signs rather than pain, which is one reason that you're probably not going to see too many tumours, apart from the fact they're rare. These are going to go to the doctors rather than to you. But with a disc herniation, this is what you can expect. Severe bilateral low back and leg pain, severe. Much like a disc herniation, but of course it's bilateral. There's severe obligate functional impairment, like a disc herniation. All range of movements are severely affected, like a disc herniation. But now you don't have a radiculopathy. This is not non-segmental. This is multi-segmental. So if you could actually pick it apart, which you really can't do, you'd pick up the different radiculopathies. But of course, everything from L5 or L4 through S4 is affected. So the pain patterns all over the back of the leg and in the crotch, paresthesias everywhere, and so on. While I'm thinking of that, people talk about saddle paresthesia, which is true, but this isn't an isolated thing. The person doesn't come in saying, I've got pins and needles in here. It's pins and needles all the way down, and you're probably going to have to ask about in the saddle area. They may well not mention it, especially if it's a female. Straight leg raises are either going to be strongly positive bilaterally, or if the nociceptors has been destroyed by the pressure of the disc, this may end up being negative on both sides or one side. So as I say, this is not something you're going to have a diagnostic problem with. Okay, so we're going to look at a patient complaining of this pain. All right, so what I want you to do is spend 5 seconds or 6 seconds looking at it. All right, now really look at it, because there's some clues in here as to what it's probably not. So just don't think this is low back and leg pain. All right, look at it. Okay, so what we have is a patient with bilateral leg pain, and the differentials I came up with here is central stenosis, bilateral disc herniation, median paramedian disc herniation, spondylolisthesis, internal disc herniation, pathological fracture, overt vertebral fracture, vertebral infection, vertebral neoplasm, viscerogenic disease. Now, before I get too far into this, I'd ask you to look very carefully at the diagram. What you should note there, this isn't simple back and leg pain. That pain is going down the outside of his foot. So this is S1. So right away, that will rule out a lot of these problems. Central stenosis will give you multi-segmental problems. So it's going to be, if this is an L5, it's going to give you L5, S1, and probably S2. And if it gets bad enough, S3 and S4, it's bad enough, you get a cauda equina syndrome. But it's going to give you much more than just S1. Bilateral disc herniation. Yeah, it's rare, but it could happen. Paramedian disc herniation, paramedian or median disc herniation, so what about cauda equina? Again, we come back to this business that this is S1. If this is a paramedian herniation or a median herniation, it's going to hit multiple roots, so you won't see it as nice and clear cut as that. Internal disc herniation, yeah, if it is, it's L5, giving you basically L5S1 referral. Pathological fracture is possible. It's very difficult to tell from anything else, and this is purely referred from the spine. Overt vertebral fracture, that's easy. Ask them if they've had trauma and a sudden onset of severe pain, and that also applies to pathological fracture. It usually has a triggering event, so if they've done something like slip or done something like that, and there's a sudden onset of their severest pain, it's a good idea to look at their age, because if this is an older age group, this may be a secondary tumour. If it's a child with this type of pain, don't mess with it. Get it out. There's any number of things it could be, but it isn't something you want to mess about. Don't think of this as a normal disc herniation. You do get disc herniations in children. I think the youngest age has been 7 years old, but that's extremely rare, and there's some predisposing factors in there as well. So don't mess with kids with a disc herniation or that type of pain. Vertebral infection, we talked about that. It's not the easiest thing to pick up. In an adult, it's going to be prolonged and protracted. There may be some temperature increase. They may feel some malaise. It's tough. Vertebral neoplasm, also difficult. This could be referral from the bone. And essentially what happens is, of course, the bone has microfracturing it, so you get some pain from the chemicals produced by the cancer, and also microfracturing the bone can be painful as well. But usually that's associated with a microfracturing. And then viscerogenic disease is very easy to sort out. Range of motion, PAs, no problem. It's not coming from the spine. Wherever it's coming from, it's not coming from the spine. So what does it leave us with? Well, bilateral disc herniation possibility. It's not going to be paramedian median disc herniation because of the specificity of the referral. It's not going to be spondylolisthesis for exactly the same reason, and the central stenosis. So it could be an internal disc herniation, very possible. Bilateral straight abrasive should be negative within the ranges you would expect to be positive. Now, if that happened and this was multi-radicular, multi-segmental problems you're seeing, then I'd be thinking about this being called requiner and no nociceptors in the dura. But this is not the case, so internal disc herniation is very reasonable. The ones that you can't really sort out in your clinic: pathological fracture, vertebral infection, neoplasm, and sometimes viscerogenic disease. Well, that one you should be able to sort out by moving the patient around. But if you look at the ones where you're going to run into trouble, these through here, all of those, and even the internal disc herniation, all of those need to be referred back to the physician. Primarily because the internal disc herniation needs to be diagnosed and it needs to be treated appropriately. And it's difficult to see what you can do about it. The only thing I've found of any real help with these patients actually is a back support, just to stop them moving too much, and it might actually relieve some of the pressure on the disc. These ones are dangerous, so these need to be sorted out as soon as you possibly can. So although you can't make a specific diagnosis with these, nor should you be able to, because you haven't got the tools to do it, nor the expertise to do it, they're going to be referred out anyway. So the diagnosis is enough for you to manage it properly. That's all you really care about here.